Welcome back to the Deep Dive. Today we're doing something a little different. We've got our hands on a single, simple source. The actual drug list for a foundational clinical pharmacology review.
Yeah, is it?
Think of this as the ultimate cheat sheet. These are the 34 pharmaceutical pillars that every single person entering clinical medicine is expected to just know cold.
It really is the raw syllabus of foundational competence. This isn't about, deep research. It's about instant recall. If you're going to be trusted with patient care, this list really defines the minimum knowledge required.
And the structure of this session itself is the key insight here. For each of these 34 drugs, the learner has to have at least 2 foundational, crucial facts ready to go. That means we're looking at a baseline of 68 core pieces of information. I mean, facts that span nearly every physiological system and every risk profile you can imagine.
And that sheer breadth is what we need to unpack. The knowledge gradient is, well, it's insane. It jumps from a simple remedy you can buy at the corner store to targeted biologic therapies used only in specialized hospitals.
A huge leap.
It is. If you want a shortcut to understanding the scope of, let's say, medical liability and knowledge, this list is it.
Okay, so let's unpack this. Our mission today is to categorize these 34 agents to truly appreciate the demand this curriculum places on you, the learner. We're going to move pretty quickly from the familiar to the formidable. We'll begin where most people start their journey with medicine: pain, inflammation, and metabolic maintenance.
Yeah.
Right here at the top are the drugs everyone thinks they know: acetaminophen and aspirin.
Right.
So why are these still considered foundational pillars that require deep, specific facts?
Well, because the clinical difference between them defines huge swaths of patient safety. Acetaminophen, Tylenol, it's a great pain and fever reducer.
Sure.
But it carries that massive risk of acute liver toxicity if you dose it incorrectly. And that's a foundational fact you simply must know.
And what about aspirin?
Aspirin is, well, it's multifaceted. I mean, fact 1, it's a pain reliever, okay?
Sure.
But fact 2, the critical clinical fact, is that its primary use in adult medicine is its irreversible antiplatelet action.
Ah, so for heart attack prevention.
Exactly. That mechanism is key, but it also dictates the massive GI bleeding risk. The knowledge is less about the pill name and more about the specific risks of how it works.
That distinction between mechanism and risk, that brings up Celecoxib, which is also on the list. How does that fit in?
It forces you to differentiate. Celecoxib is a selective KIOX2 inhibitor, so it's not like the other NSAIDs. A key fact here is that it reduces GI risk compared to, say, ibuprofen, but it carries a higher potential cardiovascular liability.
So it's a trade-off.
It's all about understanding the risk trade-offs.
And moving away from just pain relief, but staying in that common metabolic area, we immediately hit drugs for gout: Allopurinol and Colchicine.
Yes, and these are key levers for managing uric acid and acute flares. But what's equally critical, and maybe overlooked, is the inclusion of Alendronate, a common bisphosphonate for osteoporosis.
And the foundational knowledge there isn't just what it treats, is it?
No, it's how it must be taken.
You're talking about the upright position requirement.
Exactly. The key fact for Alendronate is that the patient has to remain upright for at least 30 minutes after they take it. And why? To prevent severe esophageal irritation and ulceration. That's a perfect example of a life safety, crucial fact that saves a patient from a terrible outcome. It's non-negotiable.
That conversation about safety leads us directly into our next group: agents for managing breathing difficulties, allergies, and targeted inflammation control. The list pairs the immediate crisis agent albuterol with some lesser-known long-term modifiers.
Albuterol is, it's the universal rescue inhaler. It's a fast-acting beta-2 agonist. It just opens the airways instantly. The foundational fact is its immediate effect in an asthma attack.
But that's just treating the symptom.
Exactly. If that's all you know, you're just putting a Band-Aid on it.
Right. And the curriculum is asking for more. We see classic anti-allergy agents like Azelastine, which is often a nasal spray, but then we hit Zileuton. What is the clinical importance of including Zileuton?
Zileuton is where we move from just symptomatic relief to true disease modification. It works by inhibiting the 5-lipoxygenase enzyme, and by doing that, it blocks the synthesis of leukotrienes.
And leukotrienes are major inflammation drivers.
Powerful inflammatory mediators, yes. So the clinical consequence is that Zileuton targets the underlying pathway. That makes it a critical prophylactic agent for long-term asthma control, especially for exercise-induced asthma.
So the foundational requirement isn't just memorizing names. It's about understanding the therapeutic hierarchy. When do you use the quick fix, and when do you use the drug that blocks the pathway?
Precisely. You have to master both the immediate fix and the long-term biological strategy.
Okay, so moving from the respiratory system, we enter the, let's call it the high-stakes arena of cardiovascular and coagulation management. This is where clinical liability can just skyrocket. I'm noticing two common beta blockers here, Atenolol and Carvedilol. What's the core difference a foundational learner needs to grasp between those two?
Well, atenolol is typically a selective beta-1 blocker, so it's focused primarily on the heart. Carvedilol, on the other hand, is a non-selective beta and alpha-1 blocker.
So it's broader.
Much broader. Its foundational fact is that broader action, which is often preferred in managing chronic heart failure because it helps dilate blood vessels. You have to know if the agent is just heart-focused or if it affects the vasculature, too.
That difference matters immensely, especially when we start talking about anticoagulation. The curriculum really seems to emphasize drugs that control blood flow, like the pairing of warfarin and clopidogrel.
Oh, absolutely. This suggests a critical focus on preventing strokes and cardiac events. For warfarin, the classic vitamin K antagonist, there are two non-negotiable facts you need.
Okay.
One, its mechanism involves blocking the synthesis of clotting factors in the liver. And two, it requires constant, rigorous INR monitoring because its dosage is extremely sensitive.
It's sensitive to diet, other drugs, everything.
Everything.
And clopidogrel.
Clopidogrel is an antiplatelet agent. It stops platelets from sticking together. The key clinical fact is that its effect is irreversible for the life of that platelet.
Which
means you often need to stop it days before a surgery to avoid uncontrolled bleeding. This is bedrock risk mitigation knowledge.
To round out this section, we've got two pretty specialized agents. Apraclonidine, which sounds a bit niche. I think it's used in ophthalmology.
It is, yeah, to reduce intraocular pressure.
But then we have Atropine. What makes Atropine so foundational?
Atropine is a critical agent with a huge range of uses, but its foundational use is in the ER or the ICU. It's an anticholinergic. Its most crucial fact is its role in treating symptomatic bradycardia, a dangerously slow heart rate, by blocking vagal nerve input. It's an indispensable drug for cardiac emergencies.
Here's where the syllabus takes a really sharp turn. We're moving from common critical care to the most specialized and potent agents out there.
Yeah.
Autoimmunity, cancer, high-risk therapies.
Yeah, the complexity gradient just shoots up here.
We're seeing cutting-edge stuff like Adalimumab and anakinra right next to drugs that were developed decades ago.
The inclusion of these biologics, these large engineered protein drugs, it just shows the level of sophistication required. Adalimumab is a TNF-alpha inhibitor. So fact one, it blocks a key inflammatory signal for diseases like rheumatoid arthritis.
And fact two,
because it suppresses the immune system so powerfully, you have to screen the patient for latent tuberculosis before starting treatment. That is a critical safety fact.
that's a phenomenal example, linking the mechanism directly to a screening protocol. What about anakinra?
Anakinra is an interleukin-1 receptor antagonist. So, like adalimumab, it's a targeted immune modulator. The foundational insight here is that the curriculum demands you are proficient in highly specific cytokine blocking. We're talking about using molecular smart bombs, really, to stop inflammation.
But then we pivot right back to older, yet, frankly, terrifyingly powerful cytotoxic drugs. We find traditional immunosuppressants like Azathioprine and the chemo agent, Cyclophosphamide.
Yep.
Why must a foundational course cover agents with such complex mechanisms and severe side effects?
Because they're still the backbone for treating refractory disease and certain cancers, and their safe use is entirely dependent on meticulous monitoring. For Azathioprine, a foundational fact is the risk of myelosuppression, critically low blood counts. You have to know that it suppresses the bone marrow.
And cyclophosphamide is notoriously high risk.
It is. This is a classic alkylating agent, a type of chemo. Its inclusion just screams risk management. The key foundational fact a learner has to know is the risk of hemorrhagic cystitis, severe bleeding in the bladder, and the requirement to co-administer another agent, often Mesna, to protect that bladder lining.
So when you see a drug that risky on a foundational list,
It means the curriculum is emphasizing not just if it works, but the immediate critical steps you must take to mitigate a catastrophe.
moving out of oncology and immunity, we pivot to agents acting on the nervous system and musculature, controlling everything from mood to movement. We find foundational agents for calming the brain, like the benzodiazepines group and the classic anti-seizure drug, carbamazepine.
For benzodiazepines, the foundational fact is their rapid onset of action on the GABA receptor. They quiet the central nervous system. But the crucial safety fact is the high potential for dependence and, importantly, additive respiratory depression when you combine them with other sedatives like opioids or alcohol.
And carbamazepine is a fascinating inclusion because its uses go way beyond seizures into mood stabilization.
Absolutely. It's complex because it induces its own metabolism. It's a phenomenon called autoinduction.
So it gets rid of itself.
It gets rid of itself faster the longer you're on it. So
Yeah.
fact one, it stabilizes nerve membranes. Fact two, which is clinical gold, it requires blood level monitoring. That narrow therapeutic window demands constant vigilance.
We also see clonidine on here, an alpha-2 agonist, often for hypertension. But it's now used off-label for things like ADHD or managing opioid withdrawal.
Its complexity just reflects how deeply CNS receptors regulate so many different functions. But let's look at the final drug in this section, Atracurium. This is perhaps the highest stakes drug on the entire list. It's a neuromuscular blocking agent.
So why is a drug used to paralyze a patient for surgery considered foundational knowledge for a general learner?
Because of the immediate danger, Atracurium is a non-depolarizing blocker, which means it stops all skeletal muscle movement,
Including breathing.
including breathing. The two foundational facts are simple. The patient must be mechanically ventilated, and you must have an immediate plan for reversal. Its inclusion shows that the curriculum includes the knowledge you need to support life during critical procedures. You have to know how to paralyze, and you have to know how to breathe for the patient you've paralyzed.
Okay, let's shift our focus to the skin, to dermatological health. This might seem like a lower stakes area compared to paralysis, but the curriculum demands knowledge of potency and systemic risk.
Right. This section forces you to understand the gradient of corticosteroids. The list has betamethasone and the much, much higher potency agent, clobetasol.
And the crucial fact is knowing the difference.
It's the potency ranking. Using a high-potency agent like clobetasol inappropriately, say, on the face or for too long, can cause local side effects like skin thinning or even systemic absorption, suppressing the patient's own adrenal function.
So foundational knowledge includes choosing the right strength for the right site. And beyond steroids, we have specialized skin treatments for chronic conditions.
Correct. We have common agents like adapalene, a topical retinoid, and benzoyl peroxide for acne. But then we hit the heavy hitters for severe psoriasis, acetretin, an oral retinoid, and calcipotriene, which is a vitamin D derivative.
Acetretin, being an oral retinoid, it shares some risk profiles with its more famous cousin, isotretinoin, right?
Absolutely. This is the definition of a high liability fact. The foundational fact for acetretin is its extreme teratogenicity. It causes severe birth defects.
Wow.
This means female patients must adhere to stringent mandatory pregnancy prevention programs and continue them long after stopping the drug. The curriculum requires you to know these extreme risk mitigation steps.
Finally, we arrive at the foundational anti-infectives and a rather unusual nutritional component. For antibiotics, we have the workhorse, amoxicillin, followed by its combination drug, amoxicillin clavulanate, and the highly specific injectable benzathine penicillin G.
The pairing of amoxicillin with the combo product is very deliberate. It emphasizes the foundational concept of bacterial resistance.
How so?
Well, fact one for amoxicillin clavulanate, it's effective against a broader spectrum of bacteria. Fact two is why. That effectiveness comes from the clavulanate, which acts as a suicide inhibitor. It destroys the bacterial enzyme that would otherwise render the amoxicillin useless.
So you have to understand the resistance mechanisms.
It's crucial.
That makes perfect clinical sense. But what stands out here, and what you should be mulling over, is the inclusion of vitamin B12, or cyanocobalamin, right alongside these powerful antimicrobials. Why is a vitamin considered a core drug fact?
Because it's essential management knowledge. Clinical practice isn't just about drugs that kill things, it's about fixing fundamental deficiencies that cause disease, like pernicious anemia. The key foundational fact is that in specific deficiency states, it often has to be given by injection because the patient can't absorb it orally. It proves that clinical drug facts encompass all therapeutic elements required for patient care.
Wow. That journey through 34 names and at least 68 core facts, it's really defined the scope of foundational competence. We've spanned every imaginable risk gradient from, the simple dosing risks of Tylenol to needing Mesna to prevent chemotherapy damage.
And from controlling common gout to paralyzing a patient safely for surgery.
The synthesis is so clear. This list requires you, the learner, to operate across multiple therapeutic domains: pain management, critical care, long-term disease modification with biologics, antibiotic resistance strategies.
It's less about achieving expertise in one specialty and more about possessing critical, accurate facts across nearly every physiological system when a patient's life hangs in the balance.
So what does this all mean? For the clinician, for you, the well-informed learner, it means foundational knowledge isn't abstract theory, it's immediate risk assessment. The difference between a selective beta blocker and a non-selective one, or knowing the 2-week limit on a high-potency steroid, that dictates patient safety.
And consider this final provocative thought that really ties together the complexity of this list. Given diverse mechanisms we've seen here, from simple enzyme inhibition with allopurinol to the massive structural requirements of a monoclonal antibody like adalimumab to the basic nutritional role of vitamin B12.
Hey, we have a massive mission ahead of us. We're taking a huge review of essential clinical pharmacology.
A really high-yield one.
Exactly. We're focusing on drugs from A through L, and we're going to try and distill that dense information into, clear, critical knowledge.
The absolute must-knows.
Right. The mechanisms, the clinical uses, and especially those safety alerts you just can't afford to miss. This is really the shortcut to mastering a huge chunk of the formulary.
And we're not just going down a list alphabetically. That wouldn't make sense. Context is everything here. So we've grouped these, 24+ drugs by how they actually work in the body immune system, the heart, hormones. It gives you a framework.
So when you hear about a specific warning, it connects right back to the system it's hitting.
Precisely. We're prioritizing the things that make a difference. Potency, unique drug targets, and the safety profiles that make a doctor choose one drug over another.
Okay, so let's jump right in. We can start with the heavy hitters in immune suppression and inflammation.
Let's do it. We can begin with a classic calcineurin inhibitor, cyclosporine. It's just a foundational drug for serious immunosuppression.
And the mechanism here is what's really key, isn't it?
It is. The thing you have to know is that it binds to this protein called cyclophilin. This new complex then goes and inhibits calcineurin,
Which stops interleukin-2 transcription.
right? And that completely shuts down T-cell activation.
And that blockade is what makes it so vital for preventing organ transplant rejection.
Yeah.
And it's also used for things like severe psoriasis or rheumatoid arthritis.
Exactly. But the real clinical takeaway, the thing you need to carry with you, is all about its side effects. Nephrotoxicity or kidney damage is the most common one.
And that's not a minor risk.
Not at all. It means monitoring the drug becomes this absolute clinical tightrope. You're constantly checking trough levels, trying to walk this narrow line between enough drug to stop rejection and so much that you cause renal failure.
Wow, a constant risk assessment. Okay, let's contrast that with another powerhouse for RA and psoriasis, etanercept, a biologic DR.
Right, and a totally different mechanism. This is all about protein engineering. Etanercept is what's called a fusion protein. It's essentially a soluble receptor for TNF, tumor necrosis factor.
So it just patrols the system and mops up active TNF.
It mops it up, exactly. It neutralizes its inflammatory signal. It's incredibly effective. But because you're neutralizing a key part of the immune response, the safety alert is severe.
Infection.
Serious infections. It dramatically increases the risk, including the reactivation of latent tuberculosis.
Okay, so if the risk of TB reactivation is that high, why wouldn't a physician just lean toward a small molecule DRR instead? Is the efficacy that much better?
In many cases, yes. From moderate to severe disease that's already failed first-line therapy, biologics like etanercept just offer a level of control that smaller molecules often can't match.
So it's a necessary trade-off.
It becomes a required trade-off. Aggressive disease control versus really rigorous infection screening.
That definitely puts the risk in context. Okay, let's shift from targeted immunosuppression to broad anti-inflammatory action. Let's look at glucocorticoids and their potencies. We should start at the baseline, hydrocortisone.
Hydrocortisone is easy. It's just the pharmaceutical name for our natural stress hormone. Cortisol, it's the gold standard we compare everything to, so it has an anti-inflammatory potency of 1.
And clinically, it's the go-to for replacement therapy in Addison's disease, right?
Yeah.
And acute adrenal crisis.
It's the drug of choice. And it's also worth noting that the low-potency topical versions, like a 1% cream, are safe enough for long-term use, even on sensitive skin like the face.
And then you jump way up the potency ladder to dexamethasone. This is where the numbers just get wild.
They do. Dexamethasone is a long-acting synthetic powerhouse. It is 30 times more potent as an anti-inflammatory than hydrocortisone.
30 times.
And crucially, it has almost zero salt-retaining or mineralocorticoid activity. Its uses are vast: severe inflammation, fetal lung maturation in premature infants.
It's also used for a diagnostic test, isn't it?
Absolutely. The low-dose dexamethasone suppression test. We use it to help diagnose Cushing syndrome because its potency can suppress the pituitary's release of ACT8.
And if we do need that salt-retaining action for replacement, that's where fludrocortisone comes in.
Correct. Fludrocortisone is a specialist. Its salt-retaining potency is immense, about 250 times that of hydrocortisone. Its use is very, very specific, giving that necessary salt-retaining activity in Addison's disease.
Okay, so speaking of internal balance, let's move from hormones and inflammation to the heartbeat and vascular tone, the adrenergic agents.
This is a perfect illustration of how subtle receptor differences lead to vastly different clinical outcomes. And at the top, we have the ultimate non-selective champion, epinephrine.
Non-selective, so it hits everything. Alpha 1 and 2 for vasoconstriction, and then beta 1 and 2 for heart contractility and bronchodilation.
Right.
That combination makes it the drug of choice for anaphylactic shock and cardiac arrest. Just rescues every system you need.
Then we can narrow the focus to dobutamine, which is highly selective for beta-1 receptors. Its sole job is to increase cardiac output during acute heart failure by boosting the heart's contractility and rate.
And then we have the multi-tool, dopamine, where the effect is completely dictated by the infusion rate.
This dose-dependent nature is fascinating, and it's clinically critical. At low doses, it's mostly hitting D1 and D2 receptors, which increases renal blood flow.
But that effect drops off.
It drops off quickly. Then, intermediate doses stimulate beta-1 receptors, boosting the heart. But when you get to high doses, it activates alpha receptors, leading to this profound generalized vasoconstriction.
And that high dose, that alpha effect, that links directly to its main safety alert, doesn't it?
It does. Dopamine is a potent vesicant. If it leaks out of the vein, that's called extravasation. That massive local vasoconstriction can just cut off the blood supply to the tissue and cause severe necrosis.
So IV site monitoring is absolutely crucial.
Yeah.
Okay, moving from agonists to a blocker, a really targeted one, esmolol.
Esmolol is an ultra-short-acting beta-1 selective blocker, and it's IV only. And the ultra-short-acting part is key.
Its half-life is what, 10 minutes?
Around 10 minutes, that speed gives you phenomenal minute-to-minute control over heart rate and blood pressure. It's ideal for arrhythmias or hypertension in the ICU or the OR.
Right. If things go wrong, you just stop the infusion and the clock resets almost instantly. Okay, let's shift from the heart to the skeleton. Bone density and gout.
For new generation bone density treatments, we should highlight denosumab.
It's a monoclonal antibody targeting ARN-ANKL, which is basically the signal that tells osteoclasts, the bone-chewing cells, to form and get to work.
And by inhibiting ARN-ANKL, denosumab stops that bone resorption.
It's first line for severe postmenopausal osteoporosis. But there's a key advantage for a very specific group of patients, right?
Yes, patients with renal impairment. Since denosumab isn't cleared by the kidneys, unlike a lot of bisphosphonates, it's a complete game changer for patients with renal insufficiency, even those on dialysis.
Plus, the subcutaneous injection every 6 months is great for adherence.
Much better. And we should briefly mention that estrogen also prevents bone resorption, but because of the risks, thromboembolism, certain cancers, it's just not a primary prevention strategy anymore.
Got it. Now, let's tackle gout, which has had some major safety updates recently. Let's talk about febuxostat.
Febuxostat is a non-purine xanthine oxidase inhibitor for chronic hyperuricemia. Clinically, it's useful because it requires less dose adjustment in patients with renal impairment than, say, allopurinol.
But there's a big but here.
A very big one. It comes with a mandatory black box warning for an increased risk of cardiovascular death compared to allopurinol.
Which forces a really difficult clinical decision. How do you weigh the easier renal dosing against a potential long-term risk of CV mortality?
You have to do a rigorous individual risk assessment for every single patient. It's high stakes.
Very high stakes. And then there's Lesinurad, which works on a totally different principle.
Lesinurad is a SUR, a selective uric acid reabsorption inhibitor. It inhibits the URT1 and OAT4 transporters in the kidney, which forces more uric acid out in the urine.
But the key restriction here, it can't be used alone.
It must only be used in combination with a xanthine oxidase inhibitor. Monotherapy is forbidden. It carries a significant risk of acute renal failure if you use it by itself.
Okay, that makes sense. Let's pivot now to general internal medicine, antihypertensives, skin, allergies. Let's start with the alpha-1 blockers.
Okay, doxazosine is our selective alpha-1 blocker here. It works for both hypertension and BPH, benign prostatic hyperplasia, because it relaxes smooth muscle in the blood vessel walls and in the prostate.
And the big clinical concern is that orthostatic hypotension, right? The first dose effect, where patients can get dizzy or faint after the very first pill.
Exactly. We also have labetalol, which is a versatile third-generation beta blocker that also has alpha-1 blocking activity.
Which makes it useful for severe hypertension, even IV for hypertensive emergencies. And it's also generally considered safe during pregnancy.
A key role in maternal health, yes.
For a drug that requires maybe the most extreme safety regulations we have, isotretinoin.
Isotretinoin is a first-gen oral retinoid, and it's reserved strictly for severe scarring acne. And the caution is all due to one fact. It's highly teratogenic, pregnancy category X.
Which is why we have the mandatory IPL Adjuge program, a really strict multi-step pregnancy prevention system.
The IPL-AD program is remarkable, really. It just shows how regulators have to manage the risks of one of the most effective yet most dangerous teratogens we prescribe.
And beyond that huge risk, patients also have to be warned about the common side effects. Severe dryness, hyperlipidemia, potential liver damage.
Right, hepatotoxicity. Now, for allergy agents, this is a perfect contrast between old and new drugs. Let's start with diphenhydramine.
The classic first-generation H1 antihistamine. It's effective, but the side effects are significant. Profound sedation, strong anticholinergic effects.
Dry mouth, urinary retention.
Yeah.
Because of all that, it's rarely the first choice for chronic allergic rhinitis anymore.
Which brings us to the second-generation agents like loratadine.
Exactly. It's just as effective for allergies, but the key advantage is simple. It doesn't really cross the blood-brain barrier, so it's non-sedating.
We also have topical options like fluticasone, an intranasal corticosteroid that's first line for allergic rhinitis. And because it's topical, systemic absorption is minimal.
And then there's a specialized agent, Apraclonidine. We mostly know it as a bronchodilator for COPD and asthma, but it has a niche use as a nasal spray, specifically for a runny nose for rhinorrhea.
Interesting. Okay, before we get to metabolic crosstalk, two other essential agents to round out our A to L list, diclofenac gel and GM-CSF.
Diclofenac gel is a topical NSAID. It's used for localized osteoarthritis pain in joints like the knees or hands, and the main benefit is you get fewer systemic GI side effects compared to taking an oral NSAID.
And GM-CSF, granulocyte macrophage colony stimulating factor. This is a crucial immunostimulant, but we need to know when it's used.
This is so important. GM-CSF is used to rescue bone marrow function. You use it in acute situations, like after intense chemo, to stimulate stem cells and recover from neutropenia.
Or in chronic failure, like aplastic anemia.
Right, and the timing is everything. You use it after chemo to counteract the suppression, not during the chemo itself.
That context is perfect. Okay, let's finish with two agents that show just how critical it is to understand metabolic pathways and receptor crosstalk, erythromycin and insulin.
Erythromycin is a macrolide antibiotic used topically for acne or systemically for people with penicillin allergies. It works by inhibiting bacterial protein synthesis.
But the critical interaction nugget here, the one that causes all the trouble, is its effect on liver enzymes. It's a potent inhibitor of CYP3A4.
And the implication of that inhibition is massive. If a patient is taking erythromycin, levels of any other drug metabolized by CYP3A4 will just shoot up.
We're talking about really common drugs, statins, calcium channel blockers, warfarin.
Even carbamazepine. If you don't recognize this interaction, you can cause severe toxicity from the other drug.
And finally, the foundational hormone, insulin. It binds to enzyme-linked tyrosine kinase receptors, and it promotes glucose entry into cells.
Which brings us right back to our adrenergic agents.
It all comes full circle.
It does. Remember that alpha-2 receptor stimulation actually inhibits insulin release. But the critical clinical connection is this. Beta blockers, like the esmolol or labetalol we just discussed, can severely mask the adrenergic warning symptoms of hypoglycemia.
The shaking, the sweating, the palpitations, that's the body's natural early warning system that your blood sugar is crashing.
And if the beta blocker takes that system away, the patient might skip that early stage and go straight to confusion or even a seizure. It's a profound clinical risk.
Okay, so let's zoom out for a final takeaway. We've covered cyclosporine's nephrotoxicity, that huge 30-fold potency difference in glucocorticoids, the regulatory necessity of IPL-DIG for isotretinoin, and that black box CV risk for febuxostat.
What really stands out and what we want you to think about is the deep
Welcome back to the deep dive. Today we are wading into some pretty dense, territory-essential drug profiles. We've got a huge stack of pharmacology notes here covering mechanisms, warnings, really everything for drugs from M through Z. Okay, let's unpack this. Our mission really is to take this mountain of data, I mean, it looks like 1,000 individual flashcards, and turn it into something connected, something you can actually use. We're looking for those aha moments, where the how of a drug suddenly makes the why of a safety warning just click.
It's a vast landscape, for sure. We're jumping from immunology to cardiology, and the core challenge is always the same. You have to remember that every drug mechanism, no matter how elegant, comes with a trade-off. Our goal is to connect that mechanism, the how to, the thing that really matters, the clinical risk.
Absolutely. So let's start with the really challenging area. Chronic inflammation. It's always a balancing act. And we have to begin with methotrexate, MTX. It's a cornerstone drug.
It really is. And it's such a profound tool because its mechanism is so fundamental. It's a folic acid antagonist. So it blocks an enzyme dihydrofolate reductase, and that stops DNA synthesis cold.
Which is why it's used in, like, high doses for cancer treatment.
Exactly. But the nuance comes in when we talk about rheumatoid arthritis, where it's the #1 DMARD. For RA, you dose it once weekly, and that schedule is everything.
Okay, so why is that weekly schedule so critical? What does that tell us?
That schedule is the safety window. Because MTX hits any cell that's turning over quickly, the side effects are severe. We're talking hepatotoxicity, myelosuppression, so bone marrow problems, even pulmonary fibrosis. If you dosed it daily for RA, the toxicity would be just intolerable.
So the weekly dose gives the body's healthy cells a chance to recover.
A fighting chance, yeah. And that leads right to the other critical piece of managing it.
The folic acid supplementation.
Yeah.
It seems counterintuitive, right? Why give folic acid back if the drug is designed to block it?
It's like we're trying to thread a needle. The anti-inflammatory effect we want for RA doesn't need that complete systemic shutdown. So giving back some folic acid helps rescue the healthy cells, especially in the gut and bone marrow, and that reduces the awful side effects like nausea without completely canceling out its main job.
Right. Okay, speaking of managing these conditions, let's talk steroids. They're often used as a bridge therapy. We have methylprednisolone here, which is a powerful glucocorticoid, about 5 times stronger than hydrocortisone.
And that speed and potency are key. It gives you quick relief while you're waiting for a slower drug like MTX to kick in. Now, what's fascinating is if you compare that to prednisone.
Because prednisone is a prodrug.
Right. It's inactive on its own. It has to be converted in the liver to its active form, prednisolone.
So how does that detail make a difference clinically?
Oh, it's a game changer in pregnancy. The placenta is really good at breaking down prednisone before it can become fully active. That means it's the preferred steroid for pregnant patients because it minimizes fetal exposure. It's a really unique safety profile.
That is a perfect example of mechanism dictating safety. But with any long-term steroid use, the risks just pile up.
Absolutely. The chronic effects are systemic. You're driving up the risk for osteoporosis, messing with blood sugar. And then you get the classic Cushingoid symptoms, the fat redistribution, muscle wasting. They are not a long-term solution if you can help it.
Okay, let's move into the more targeted therapies, the biologics. Let's talk about rituximab.
Rituximab is a non-TNF biologic. It's a monoclonal antibody, and it's very specific. It binds to the CD20 antigen, which you only find on D cells.
And when it binds, it basically puts a target on that B cell's back.
Pretty much. It flags it for destruction, so you get B cell depletion. By taking out the B cells, you reduce autoantibody production and just sort of cool down the whole immune response.
And the warning flows right from that. Serious infusion reactions and, of course, you have to avoid live vaccines because the immune system is compromised.
Precisely. And we see another really specific mechanism with Mycophenolate Mofetil. It's used a lot in organ transplantation.
Mycophenolate targets lymphocyte proliferation.
It does, but in a very clever way. It inhibits an enzyme called IMPDH. This blocks the creation of guanosine, and it turns out T and B lymphocytes are super dependent on this pathway to multiply, so you get this targeted immunosuppression without, completely wrecking the whole body.
That's incredibly selective. Now, what about the newest generation, the oral JAK inhibitors like upadacitinib? These sound powerful but risky.
They're the definition of high risk, high reward. They block the Janus kinase pathways, which are involved in a ton of inflammatory signals. But because that system is so central to immune surveillance, the FDA has slapped some serious black box warnings on it.
What are we talking?
Increased risk of severe infections, cancer, blood clots, and even all-cause mortality. It's a really serious conversation to have with the patient.
Okay, let's shift gears to a very specific inflammatory disorder, gout. We have pegloticase here.
Yeah.
Sounds intense.
It is. It's reserved for the worst of the worst cases of chronic gout. It's basically a recombinant enzyme, a uricase, that breaks down uric acid into something that's super water-soluble, allantoin. The problem is it's an IV infusion every 2 weeks. And because it's not a human protein, the risk of anaphylaxis is significant.
And on the other side of gout management, we have probenecid.
Ah, yeah, the classic uricosuric agent. Its job is to block uric acid from being reabsorbed in the kidney, so you just pee more of it out.
But that mechanism also creates its biggest contraindication.
Exactly. You cannot give it to patients with a history of kidney stones or poor kidney function. You're essentially flooding their renal system with uric acid, which could make things much worse.
And here's that amazing historical tidbit. It competes with penicillin for secretion.
Yeah. It actually slows down the kidney's ability to clear penicillin, so it increases penicillin levels in the blood. A great little piece of pharmacology trivia.
Okay, let's pivot completely now. Section 2. Cardiac control, the adrenergic system. Let's start with the big differences between beta blockers, starting with the classic propranolol.
Propranolol is your first-generation non-selective beta blocker. It hits both beta-1 receptors in the heart and beta-2 in the lungs. It's also very lipid-soluble, so it gets into the brain easily.
Which is why it's used for things like migraine prevention or tremors.
Right. It has a calming effect on the central nervous system.
Oh, okay.
But that B2 blockade is also its biggest liability.
Because it causes bronchoconstriction.
Exactly. For anyone with asthma or severe COPD, propranolol is an absolute no-go. You could trigger a life-threatening asthma attack.
Which is why we have metoprolol, the cardioselective workhorse.
Metoprolol is a selective beta-1 blocker, so much safer for patients with lung disease, though you still have to be cautious. It's a go-to for hypertension, heart failure. But, you know, its half-life is really short, only 3 to 4 hours, so dosing is frequent. What's fascinating here is how the third-generation agents evolved, like nebivolol. It's not just highly beta-1 selective.
It has another trick up its sleeve.
It does. It also stimulates nitric oxide release from the endothelial cells, which causes vasodilation.
So you get heart rate control and you get the blood vessels to relax. It's like a 2-for-1.
Precisely. Plus, it doesn't mess with your lipids or insulin sensitivity, which is a huge bonus. And its half-life is long. We're talking 11 to 30 hours. Once-a-day dosing, much more stable control.
Let's talk about another beta blocker, timolol. Used locally, but it can have systemic risks.
Right. Timolol is used as eye drops for glaucoma. It's a first-line treatment. It lowers eye pressure by reducing how much aqueous humor the eye makes.
But the danger is that even eye drops get absorbed into the body.
It's a key clinical point. The drops drain through the tear ducts into the nasal cavity and get absorbed systemically. So you can still cause bradycardia or, critically, bronchospasm in a patient who has no idea their eye drops could affect their lungs.
Okay, let's flip to the alpha side of the system. Phenoxybenzamine is an interesting one because of its binding.
This is a great one conceptually. It's a non-selective alpha blocker, but it binds irreversibly, covalently. It's like it glues itself to the receptor for the entire life of that receptor.
Which makes it perfect for managing something like pheochromocytoma.
Right, but that permanent blockade causes a huge drop in blood pressure, so the body's response is reflex tachycardia.
Now contrast that with the alpha agonists, like phenylephrine.
Phenylephrine is an alpha-1 selective agonist, causes intense vasoconstriction. You see it used to treat hypotension or, topically as a short-acting nasal decongestant. Works for about 4 hours.
Which brings us to oxymetazoline, another topical decongestant, but this one is long-acting, up to 12 hours, and it comes with a very specific warning.
This is a massive patient education point. You cannot use it for more than 3 days in a row.
Why not?
Because the blood vessels in your nose become dependent on it. When you stop, you get this massive rebound effect, rhinitis medicamentosa. The rebound congestion is often way worse than the cold you started with.
Here's where it gets really interesting. Let's dig into some dangerous interactions, starting with probably the most famous one, warfarin and sulfonamides.
Ah, warfarin. The poster child for a narrow therapeutic index drug. The dose that helps you is dangerously close to the dose that hurts you. But the key to its interactions is its binding profile. Warfarin is 99% bound to plasma albumin.
So almost none of it is actually free and active at any given time.
Almost none. So now imagine a sulfonamide antibiotic comes along. It competes for those same binding sites on albumin, and it kicks the warfarin off.
So even if it only kicks a little bit off, say 1%, you've just doubled the amount of free active warfarin in the blood.
You've doubled it instantly. And that sends the INR soaring and creates a massive, potentially fatal bleeding risk. That concept displacement from protein binding is everything.
And we should remember that sulfa drugs are also a common cause of severe allergic reactions, like SJS.
A huge connection to make. Always check for a sulfa allergy.
Now for a different kind of interaction dilemma, omeprazole and clopidogrel.
Yeah, this is a constant challenge. Omeprazole, a PPI, is great for protecting the stomach, but it inhibits an enzyme called CYP2C19.
And why is that a problem for heart patients?
Because CYP2C19 is what's needed to activate clopidogrel, the antiplatelet drug. Clopidogrel is a prodrug, so if you block its activation, you're reducing its effectiveness.
So you're stuck. You're protecting the gut, but potentially putting the heart at risk.
It's a trade-off that has to be managed very carefully.
Okay, let's shift to some specific nervous system targets.
Yeah.
Two drugs that are basically opposites, oxybutynin and pilocarpine.
Right. Oxybutynin treats overactive bladder. It's an antimuscarinic, so it blocks M3 receptors in the bladder, calming it down. And because it's blocking those receptors, you get all the classic anticholinergic side effects.
The can't see, can't pee, can't spit, can't poop mantra.
That's the one. And pilocarpine is the exact opposite. It's a direct-acting cholinergic agonist. It stimulates those muscarinic receptors.
So it's used for glaucoma, but also orally to treat dry mouth.
Exactly. It's a sialagogue. It makes you produce more saliva. Same mechanism, totally different applications.
And quickly, for degenerative diseases, rivastigmine for Alzheimer's and selegiline for Parkinson's.
Rivastigmine is an acetylcholinesterase inhibitor. It boosts acetylcholine in the brain to help with memory. Selegiline is an MAO-B inhibitor. It stops the breakdown of dopamine, which helps mitigate Parkinson's symptoms.
All right, let's finish up with section 4. A few high-yield clinical gems. I want to start with teriparatide for osteoporosis because its mechanism is so unique.
It's a fascinating drug. Most osteoporosis treatments are anti-resorptive. They stop bone from breaking down. Teriparatide is different. It's a recombinant PTH analog that actually stimulates the osteoblasts, the cells that build new bone.
So it's anabolic. It's a bone builder. But that power comes with a serious warning.
It does. Because you're stimulating rapid bone growth, there's a black box warning for a potential risk of osteosarcoma, a type of bone cancer. It's only for very high-risk patients.
For asthma, let's clarify salmeterol.
Salmeterol is a LABA, a long-acting beta-2 agonist. The key word is long-acting. This is for maintenance only. Never, ever for an acute asthma attack. It's too slow.
And then there's Zileuton, which hits a totally different pathway.
Zileuton inhibits 5-lipoxygenase. It blocks the synthesis of leukotrienes, which are major drivers of inflammation in the lungs, so it's used for chronic prevention.
Quick hit on afloxacin.
A fluoroquinolone. We want to highlight its non-systemic uses. It's great as eardrops for otitis media, even with a perforated eardrum, and as eye drops for bacterial conjunctivitis.
And oprovican.
Oprovican is recombinant interleukin-11. It's an immunostimulant specifically used to treat thrombocytopenia, which is a dangerously low platelet count.
Okay, one last biological mechanism that's so fundamental. Vitamin B12 absorption.
This is just classic biology. B12 is way too big to be absorbed passively. It needs something called intrinsic factor, which is made in the stomach. The B12 intrinsic factor complex then travels all the way down to the ileum, the end of the small intestine, to be absorbed.
So if you don't have intrinsic factor, you can't absorb B12 and you end up with anemia.
That's it. No intrinsic factor, no absorption.
And finally, to wrap our list, the newest topical retinoid, trifarotene.
Trifarotene is a fourth-gen retinoid, a selective RAR gamma agonist. It's approved for acne, even in kids as young as 9. But like all retinoids, it's a huge teratogen, must be avoided in pregnancy. If we connect this to the bigger picture, what we've really seen today is that so much of this boils down to one question: what's the mechanism? If you understand that a drug is a prodrug like prednisone, or an irreversible binder like phenoxybenzamine, or highly protein-bound like warfarin, you can predict its effect and its most dangerous side effect.
So what does this all mean? I mean, the sheer diversity of targets we've covered, from a receptor in the ileum to B cells to enzymes in the liver, it just shows that you have to master these core concepts to practice safely. If you understand the mechanism, the list of warnings stops being just a list you have to memorize. It becomes a consequence you can predict. So think about this. We talked about how warfarin's super long half-life means it takes days to reach a steady state. But then we have metoprolol, a crucial cardiac drug, with a half-life of only 3 or 4 hours. How might that massive difference in half-life between those two drugs, short-acting metoprolol versus long-acting warfarin, fundamentally change how a doctor thinks about daily monitoring, or even just the risk of a patient missing a single dose? Something to mull over until our next deep dive. Welcome back to the Deep Dive. Today, we are taking on a huge topic. We're decoding the core pharmacological strategy of otolaryngology.
Right, the whole toolkit of medications for the ear, nose, and throat.
Exactly. And we have this really dense list of sources, drug classes, specific names, everything. But the mission today isn't just to memorize a list.
No, absolutely not. It's to understand the logic.
The logic, yes.
Because that's the real shortcut. When you look at all these drugs together, you almost immediately see a theme that's built around anatomy.
How so?
Well, the ENT system is just so sensitive, so interconnected. So the medical strategy has this really sharp divide. Are we going for a systemic effect, affecting the whole body?
Or are we going for something super targeted?
Precisely. A hyper-precise local action right at the source of the problem.
Okay, let's unpack this then. We're going to sort all this information by, I guess, function and how it's delivered.
And we have to start with the big guns.
The corticosteroids, the most powerful class for managing all that swelling and inflammation.
I mean, in ENT, inflammation is the enemy. It really is.
It's the core issue.
It's the core issue. It causes swelling, which leads to blockages, to pain, sometimes even, functional losses like sudden hearing loss.
And these are the heavy artillery.
They are. They suppress that aggressive immune response.
And the sources make it really clear that how you take them is everything. It separates them into systemic agents, the oral pills, and the local ones.
Right.
For that broad systemic relief, our sources list 4 really powerful oral corticosteroids: dexamethasone, methylprednisolone, prednisone, and prednisolone.
And when a physician reaches for one of those 4 names, they're looking for something comprehensive, something fast.
For serious acute events.
Absolutely. And, what's important for you to realize is the choice between those 4 often just comes down to potency and how long they last. So, for example, dexamethasone is incredibly potent. It has a long half-life, which makes it a really common choice for urgent short-term issues where you need that high-level immunosuppression and you need it now.
Like that sudden hearing loss you mentioned.
Exactly. A classic example.
So if you see those 4 names, you should be thinking maximum force.
Maximum force, but also maximum potential for systemic side effects.
Because it's circulating everywhere in your body.
It is. It's a trade-off. You accept that higher systemic risk because you absolutely need the systemic relief.
Okay, but then there's the other side of the steroid coin. The drugs designed for targeted local delivery.
Yes.
These are the inhalers, the intranasal corticosteroids. And we have 6 key players on our list: beclomethasone, budesonide, cyclophosphamide, fluticasone, mometasone, and triamcinolone.
And here, the clinical goal is, it's drastically different.
This isn't for a crisis.
No, not at all. These 6 are the long-term workhorses. They're for chronic conditions like allergic rhinitis or chronic sinusitis.
But by delivering them right into the nasal passages.
You maximize the anti-inflammatory effect right where the lining is swollen, but you keep the overall dose low enough to avoid most of those serious systemic effects you'd get from a pill.
I think that's the single most important insight from this entire list: the delivery mechanism. It's almost more important than the drug class itself.
Oh, it governs everything, both effectiveness and long-term safety.
And it absolutely does.
And that whole difference between local and systemic strategy, it carries over perfectly into our next huge category.
Antihistamines.
Antihistamines.
And this is where you get a really cool historical perspective, right? Seeing how the science evolved. The list just splits so neatly into the older first-generation drugs and the newer second-gen agents.
And if you connect this to the bigger picture, the one defining factor is how well they cross the blood-brain barrier. That one little detail changed everything.
So the older ones, the first-generation antihistamines, I think everyone's familiar with these, mostly because of their side effects.
Yeah.
Our sources list 2 big examples: diphenhydramine and chlorpheniramine. And I think for the listener, one of those names is what you think of when you need to get to sleep.
And that is because of the blood-brain barrier. When those drugs cross into the central nervous system, they don't just block the histamine receptors for allergy symptoms.
They hit the brain.
They hit the brain, and they trigger that characteristic sedation, that drowsiness. Now, they're highly effective at stopping an acute allergic reaction, but they really limit your daytime activity.
But I see chlorpheniramine is still in a lot of over-the-counter cold and flu stuff.
It is. Because it's effective, it's cheap, and frankly, a little drowsiness might be welcome when you're sick in bed anyway.
That makes perfect sense. So the entire design philosophy for the second generation was just solve that sedation problem.
That was the goal.
And our list of the core oral second-gen drugs is much longer. Fexofenadine, loratadine, disloratadine, cetirizine, and the levocetirizine.
These newer agents are, they're really pharmacological triumphs. They were engineered to target the peripheral H1 receptors.
The ones causing the itching and sneezing.
Exactly, without easily getting into the central nervous system.
So patients can manage their chronic allergies every day.
Without the cognitive fog. It's the difference between being functional and being, well, slightly impaired.
But what stands out to me is that the antihistamine list in our sources, it goes way beyond just those daily pills. There's a whole other group of agents listed.
Yes.
And it seems like they fill very specific clinical roles, especially with the inner ear.
This extended list is critical in the ENT world. It's got names like hydroxyzine, meclizine, and promethazine. And while, yes, technically they're antihistamines, they are often chosen specifically for their central effects.
Not to treat a runny nose.
Not at all. It's to manage symptoms like vertigo, dizziness, motion sickness, things that are common with inner ear or vestibular disorders. Meclizine, for instance, is the absolute classic go-to for vestibular suppression.
That's a great connection because vertigo often starts in the ear. So those anti-vertigo drugs are crucial tools for the otolaryngologist, even if the mechanism is basically sedation.
Exactly. And don't forget the truly local agents on the list, too. Names like Allopurinol and Azelastine.
They show up a few times.
They do, which tells you how useful they are. They can be formulated as eye drops for allergic conjunctivitis or as nasal sprays for local rhinitis, giving you rapid, localized control without any of the systemic exposure from a pill.
That focus on localized effect brings us right into our third section, which is all about acute congestion relief. Let's talk about nasal decongestants. We have a list of 5 specific agents here: phenylephrine, nephisoline, tetrahydrozoline, oxymetazoline, and xylometazoline. So what do they actually do?
These 5 names all work through the same really rapid mechanism: vasoconstriction.
Meaning?
They're alpha-adrenergic agonists. I mean, think of them as tiny little clamps.
Okay.
When you apply them to the nasal mucosa, they cause the swollen blood vessels inside your nose to just immediately shrink.
And that clears the airway.
Instantly. It reduces the fluid, the blood flow, and you can breathe again.
So this is the stuff people grab off the shelf when they absolutely have to breathe through their nose right now.
It is the ultimate quick fix. But this is also where we have to deliver one of the most important warnings from our source material.
Which is?
The danger of rebound congestion.
Ah, right.
Because these are so powerful, if you use them for more than about 3 days, the blood vessels actually become dependent on the drug. So when the drug wears off, the vessels swell up even worse than they were before. It's a cycle called rhinitis medicamentosa, and it's a huge clinical issue that ENTs have to manage.
That is critical context.
Yeah.
It's a quick fix, but with a major downside if you misuse it.
A major one.
Okay, now for the final part of our list, which was maybe the most complex. It deals with 3 specialty nonsteroidal agents that are used intranasally.
Right.
They aren't steroids. They aren't classic antihistamines. The names are Cromolyn Sodium, Montelukistan, and Ipratropium bromide. What unique niches do these 3 fill?
This little trio shows you just how specialized the toolkit can get when the first-line treatments aren't quite right. Let's start with Cromolyn Sodium.
Okay.
It's a preventative drug. It's a mast cell stabilizer.
So what does that mean?
It means it stabilizes the cells that store histamine. So if you use it before you're exposed to an allergen, the mast cells are just less likely to rupture and release all those chemicals that cause the reaction.
So it's like a proactive shield. If you know your seasonal allergies are about to kick in, or you're going to a friend's house with a cat?
Exactly. And it has an incredibly safe profile, which makes it a really good choice for people who want to avoid even local steroids, or for young kids.
Okay, next up is Montelukast. I usually hear about this one for asthma. How does it fit into the ENT world?
Montelukast takes aim at a completely different chemical pathway. the leukotrienes.
Okay.
And leukotrienes are really potent inflammatory chemicals, often more active in certain kinds of chronic severe inflammation. So a doctor might choose montelukast if a patient has coexisting conditions like nasal polyps or asthma, where leukotrienes are a major player.
So it's an oral, non-steroidal option for deep inflammation.
It is. It's essential if a patient can't tolerate nasal steroids or just needs that extra bit of therapy. It's tackling a different molecular path.
Got it. Okay, finally, ipratropium bromide. This one feels really specific.
It is the most specific of the bunch. It's an anticholinergic agent, and its main function is basically turning off the tap for a super watery, runny nose, rhinorrhea.
Which it just stops the dripping?
It stops the dripping. And what's important is it doesn't treat the allergy or the inflammation. It only treats the secretions.
And why is that distinction, not treating the allergy, so important?
Because it makes it the perfect solution for non-allergic rhinitis. Think vasomotor rhinitis or even that runny nose you get when you eat really spicy food. In those cases, the problem isn't histamine or inflammation. It's an overactive nervous response. Ipratropium bromide just blocks that signal and dries up the nose without any of the other risks. And that context of clinical choice, that's the absolute core takeaway here.
That detail really unpacks the complexity. Okay, to quickly synthesize all this, we've cut through the noise by focusing on, well, 3 major groups.
Yeah.
The corticosteroids, defined by their power, and that local versus systemic delivery.
Right.
The antihistamines, defined by that generational leap away from the blood-brain barrier. And finally, the decongestants and the specialty agents, which offer either that rapid relief or really targeted non-steroid options.
The core lesson from this whole list for you, the learner, is that expertise in this field really hinges on understanding those 2 things, where the drug acts local versus systemic and the specific mechanism it targets.
Because that context dictates everything.
Everything. Effectiveness, safety, and at the end of the day, the patient's quality of life.
So what does this all mean? I mean, the sheer variety of names we reviewed, especially in those specialty categories, it just shows that ENT treatment is this deeply specialized pharmacology. It's not just giving a patient an allergy medicine.
No, it's about precisely choosing mometasone over fluticasone, or knowing to grab ipratropium for a non-allergic watery nose instead of a systemic pill.
It's precision medicine tailored to the plumbing of the head.
That's a great way to put it.
So, given this extensive list we have today, all these powerful local and systemic agents, and knowing how much the delivery system determines the outcome, what's the next frontier for ENT drugs? Is it developing completely new drug classes that target, say, the structural changes you see in chronic sinus disease? Or is the future just about building better, even more targeted delivery systems for the powerful drugs we already have? Something for you to consider as you watch this field continue to evolve.
The human immune system is, it's the ultimate biological regulator. It's incredibly powerful.
So powerful. But that power, it's a double-edged sword, right? It has to be controlled with absolute precision.
Because if it's too enthusiastic, it can mistake your own body for the threat.
It's the tightest of tightrope walks. And for decades, clinicians have been building this amazing pharmacological toolbox to manage that balance.
And that's exactly what we're doing today. A deep dive into that toolbox, looking at the index of drugs used to flip those internal switches.
Our mission, really, is to look at the 2 opposing needs. On one hand, you had to tame an overzealous system.
Right. Things like autoimmunity or after an organ transplant, you need to turn the volume down. That's where the immunosuppressive drugs come in.
Exactly. And then on the complete other side, you have the immunostimulant agents. These are for when the system is weak and you need to turn the volume up to fight infection or even cancer.
Okay, let's unpack that. I think we should start with the heavy artillery, the immunosuppressive drugs. This is really where the whole field began, wasn't it?
It was, driven by the urgent need to stop transplant rejection. So our sources lay out 5 distinct strategies here, starting with the broadest approach.
And that would be the glucocorticoids.
Yes. If some of the newer drugs are like a sniper rifle, these are the pharmacological sledgehammer, the key examples being methylprednisolone and dexamethasone.
And they're a sledgehammer because they just act so widely. They hit everything.
They do. They suppress that first wave of inflammation. They reduce the activity of so many different immune cells. They're often your first line of defense.
In an acute crisis.
In a crisis, exactly. The thing is, their action is so rapid and so pervasive, they sort of hit a master reset button.
Yeah.
But that's also their biggest problem.
The side effects.
The side effects from chronic use can be really significant, so you use them to win the immediate battle. But then you have to quickly shift to something more targeted.
Which brings us to the second strategy, right? targeting cell division.
Right. The idea here is that the immune system relies on rapid proliferation. T cells, B cells, they have to multiply like crazy to mount an attack.
So if you stop them from multiplying, you stop the war before it really gets going.
Precisely. And you do this in two main ways. The first is with what we call cytostatic agents. These are directly toxic to any cell that's dividing rapidly.
The classic example being cyclophosphamide.
That's the one. And then there's a second, slightly sneakier method, the antimetabolites.
I find this mechanism so clever. Instead of a direct attack, they go undercover.
It's biological deception, you're right. They pretend to be essential building blocks for DNA. The immune cell tries to use them, but it can't. So it basically starves itself of the ability to replicate.
And the main players there are methotrexate and azathioprine.
Cornerstones of the strategy. So we've gone from the sledgehammer to now, targeted starvation of dividing cells.
But the next step in this evolution is even more specific. We move away from general toxicity and toward, inhibiting specific signals.
A monumental shift. This is the world of drugs acting on immunophilins.
Okay, explain that. Immunophilins.
They're proteins inside the T cell. And when these drugs bind to them, they interrupt the exact signaling pathway that tells a T cell to activate. We're no longer just killing cells, we're preventing them from ever getting the go signal.
And this is where cyclosporine and tacrolimus come in. I mean, these are the foundation of modern transplant medicine.
Absolutely. Their discovery was a huge leap forward. You got powerful immunosuppression, but it was so much more specific to T cell activation.
So how does tacrolimus work, for example?
It's much more potent than cyclosporine, but it works in a similar way. It specifically stops the production of a cytokine called IL-2.
Interleukin-2, the main growth signal for T cells.
The main growth signal. You block that, and the T cells just can't build their army to attack the new organ.
Okay, so that's incredibly specific. But the real pinnacle of specificity, that has to be our fourth category, the biologics.
Oh, without a doubt. If immunophilins were a shift, biologics are a full-blown revolution.
We're talking about monoclonal antibodies here.
Yes, we're not using simple chemistry anymore. We are literally using custom-engineered proteins antibodies that are designed to hit one single specific target on an immune cell. It is the definition of precision.
And the list of examples we have just shows the variety. We can target T cells directly with something like mirmonab CD3.
Right, which binds to the CD3 receptor complex, which is essential for activating a T cell. Or you can go after B cells with rituximab.
And rituximab has been huge, not just for lymphomas, but for some autoimmune diseases too, right?
It's a total game changer. It targets a marker called CD20 on B cells and just wipes them out. It's incredibly effective when B cells are driving the problem.
Then you've got antibodies that block the signals themselves. The index lists daclizumab,
which blocks the receptor for IL-2. Remember we said IL-2 is the growth factor.
Right, so instead of stopping its production like tacrolimus, this drug just blocks the docking station so the signal can't be received.
Exactly. It's another powerful break on T-cell expansion. But maybe the most impactful group clinically has been the ones that target inflammatory mediators.
You're talking about infliximab and adalimumab.
The TNF-alpha blockers. These two drugs completely revolutionized how we treat things like rheumatoid arthritis and inflammatory bowel disease.
And it's important to understand why. Tumor necrosis factor alpha, or TNF-alpha, it's one of the foundational signals of inflammation.
It's a master switch. So by soaking it up with these antibodies, you shut down the core engine that drives all that chronic destructive inflammation.
The fact that there are 5 different antibody examples right here in our source material, that says a lot about where the field is heading.
It tells you everything. It's all about moving away from broad suppression and toward these highly targeted pathway-specific agents.
Okay, so we've covered all the major ways to put the immune system in check. Now let's flip the script entirely. We're moving from suppression to stimulation.
From turning the volume down to cranking it way up. This is critical in areas like oncology or recovery from bone marrow failure. And we start with logistics. The colony-stimulating factors, or CSFs.
I always think of CSFs as the growth hormones for the immune system. They're telling the bone marrow, hey, we need more troops, make more cells.
That's a perfect analogy. And you need them when, say, high-dose chemo has wiped out a patient's neutrophils. You have to regenerate those cell lines fast to prevent deadly infections.
Our source breaks them down nicely. You've got GM-CSF for granulocytes and monocytes.
Then there's G-CSF, which is more specific. It just stimulates neutrophil production. For anyone studying, it's useful to know the trade name here is filgradim. Its main job is saving lives post-chemo.
The index also lists oprelvicin.
also known as Numega. That one is for stimulating platelet production.
Right.
Also crucial after bone marrow suppression.
And finally, rounding out the CSFs, we have aldesleukin.
Or proleukin. Now, this one is really interesting. It's actually a recombinant form of IL-2.
Wait, IL-2, the same signal we were just talking about blocking with daclizumab.
The very same one. Here, instead of blocking it, we're injecting pure IL-2 to stimulate T cells, specifically to get them to attack certain types of cancer.
That contrast is just incredible. The same molecule can be a target for suppression in one context and a tool for stimulation in another.
It really highlights how context-dependent all of this is. So if CSFs are about building the army, our next two categories are about signaling and strategic prevention.
Let's hit the signaling molecules first, the interferons.
Right, these are the body's natural alarm bells. When a cell gets infected with a virus, it releases interferons to warn all the neighboring cells to put their defenses up.
Puts the whole neighborhood on high alert.
A very high alert. And we use them clinically to kick the whole immune system into a state of readiness.
And finally, we get to the ultimate, the most classic form of immune enhancement, vaccines.
The training exercise. It's a proactive strategy, not a reactive one. You introduce the immune system to a harmless piece of the enemy.
The antigen.
The antigen, yes. By doing that, you teach the immune cells how to fight the real pathogen before you ever even encounter it.
And our source just lists the basic distinction here between bacterial and viral vaccines.
Enforcing that even with prevention, the strategy has to be tailored to the threat. So yeah, we've covered the whole spectrum.
What an immense journey, from the broad power of something like methylprednisolone all the way to the molecular precision of adalimumab. I think the core takeaway for you, the learner, has to be the sheer diversity of targets we now have.
It's not a simple on-off switch anymore. It's an entire control room.
Yeah.
And understanding this index helps you appreciate the nuanced decisions that clinicians have to make every single day.
Which leads us to the final thought we want to leave you with. We've talked about drugs designed to kill dividing cells, like the cytostatics, and other drugs designed to grow new cell colonies, like the CSFs. Given this incredible power, what are the life-altering trade-offs a patient has to make when they commit to chronic immunosuppression?
How does their entire risk profile change, not just from their original disease, but from the treatment itself? How vulnerable do they become to a secondary threat, to some opportunistic infection down the line? It's the ultimate balancing act in medicine. Something to ponder. Thank you for joining us for this deep dive.